that came about from our previous roundtable discussion. Jeff has several questions of his own. So welcome, Jeff. Welcome, Professor Seyfried. I thank you both for being here today for this important discussion.
Thank you. Nice to be here.
Yes, thanks, Kerry.
Professor Seyfried, could you please explain in simple, sort of layman's terms, how the metabolic theory of cancer differs from the traditional genetic mutation model?
Well, it's called the somatic mutation theory versus the mitochondrial metabolic theory. In one theory, the somatic mutation theory says that all cancers are caused by mutations in the nuclear genome. And that underlies the strategy for precision medicine and personalized therapy and these kinds of things. The other theory, the correct theory, the mitochondrial metabolic theory, says that the mutations are certainly there, but they're downstream effects of the damage to the energy producing organelle in the cell, which is called the mitochondrion. So a damaged mitochondrion will produce reactive oxygen species, ROS. These are carcinogenic and mutagenic. So the mutations that we see in many cancer cells or many tumors, all kinds of mutations, are downstream effects of the damage to the respiration. So what that means is that the cells can't get energy from oxygen. Cancer cells cannot. They can grow in the absence of oxygen, clear indication that they've got a real problem. They're using fermentation, which is an ancient pathway to get energy without oxygen. And we have interrogated all the amino acids and fuels that these cells can try to use. And all of our findings and many other findings from other investigators point to glucose and glutamine as the only two major fuels that can drive the dysregulated growth of tumor cells. And because they have that respiration defect, they can't use fatty acids or ketone bodies as an alternative fuel for glucose and glutamine. You need to respire fatty acids and ketone bodies. You need oxygen to get the energy. And tumor cells don't use oxygen. They grow in fermentation metabolism. So the solution, the pathway to the management of all major cancers is to simultaneously restrict the availability of glucose and glutamine while transitioning the body to fatty acids and ketone bodies. And this way, the tumors are marginalized and destroyed without toxicity. So this will be eventually the standard of care. It's just going to take, I don't know how many years, because it's a disruptive technology. It's a disruptive concept, and it's not going to be taken lightly by the system, which is the hospitals, the pharmaceutical industries, and all of the current organizations that treat and try to manage cancer.
All right. Thank you for that, Professor Seyfried. And for anyone watching that wants to learn more about that, we'll have a link in the description below. In the previous roundtable video, we dig into that a lot further. So Jeff, I'll hand it over to you now. I know you had some questions, some follow-up questions from our last meeting.
Yes, thanks, Kerry, and thanks, Professor Seyfried, for laying that out in layman's terms.
Do you think Jeff? Do you think that was in layman's terms?
Well, I'll be honest with you. I probably have to rewatch it. No.
Listen, yes. One of the things I have to emphasize in my lectures here at Boston College, we pound home scientific literacy. Without scientific literacy, you might as well be speaking in hieroglyphics or some other strange in tongues, okay? Yes. Because people can't understand. Listen, when your life is on the line with a disease that could potentially kill you, it becomes important to become scientifically literate as fast as you possibly can. Otherwise, you could be swept away. So yeah, I understand. Some of these, what I get, the overview that I just gave you is really a tiny snapshot of decades and decades of scientific hard research done in the laboratories. So, and I know it can be sometimes overwhelming for some folks that aren't working in the trenches like we are. But we try to do our best. And what I can do is attempt to answer any question in greater detail that might be necessary to convey the message.
Absolutely. And that scientific literacy went back to the works of Otto Warburg. Is that correct? That's basically where you have started from?
I have started from what Otto Warburg had found, yes.
Yeah, that's awesome. So Professor Seifert and Carrie, when we did that round table, I learned a lot from Professor Seifert. And I think when we did the round table, that was a few months ago, I was coming off a chemo break. I did chemo from, and by the way, everybody, that there's new people tuning in, I think right now, I have stage 4 colon cancer that has fully metastasized to the liver. And I've been on this journey that I'm on for about 22 months now. I was fully diagnosed in April of 2022. So I'm coming up on 2 years. And when we did the round table conversation, I did a full year of chemotherapy. I think my chemotherapy, and I'm probably going to be saying this wrong, Full Fury with 5FU, the bottle. I did that for a full 12 months, every other week. And along with my own type of metabolic therapy that I created in terms of diet, supplements, fasting, exercise, naturopath, osteopath, a whole bunch of different regimens that I added on to chemo that your traditional chemo patient does not really do, because they put all their trust in the medical doctors, which is fine. It's good. But I think I know that Carrie has taught me, and yourself, Professor Seifert, has taught me, you need to take things in your own hands. And like you said, you have to understand the scientific literacy of what's going on at the cellular level. So the last time we talked, I started up chemo. I had a chemo break from June, July, and August. And then I started up chemo in September. And basically, after my 3 months of that chemo, we had a scan, and my 2 tumors on my liver grew a little bit. So that forced my oncologist to take me off Full Fury, and now I'm on the second line of chemo. I think off the top of my head, Professor Seifert, I think it's FOLFOX is what it's called, something along that line. And so I'm on FOLFOX with the 5FU bottle as well. So I started that. Tomorrow I have chemo again. It's my third round of the new second line of chemo, FOLFOX. And I'm not taking it as a setback. I'm taking it as a side shuffle. I think in the summertime when I was off chemo, my father got sick and he passed away in September. So there was a lot of stresses, I think, on my mitochondria, along with I probably slacked a little bit when it came to metabolic therapy. So there was a lot of stresses that I don't think it was just me being off chemo that caused a couple tumors to respond the way it did. But I'm on track now. I just got back from a vacation in Florida with my family for 10 nights. And I exercised every single day on the beach with my sons, and I ate carnivore. I'll be honest with you, I was a little bit more keto because I had some keto desserts with my family. I was taking my supplements. I was exercising. I was getting the vitamin D from the South Florida sunshine. So I was I'm feeling really good. I just got home last night to Ontario. That's where I live. It's kind of depressing today because there's snow and slush and rain coming down. I'm sure the weather in Boston is probably not the greatest either. Yeah. But anyways, that was just a summary. Carrie, was that okay that I just did that?
Yeah, absolutely.
Yeah. And, I have a bunch of questions for you, Professor Seifert. And I think I'll probably start with, you've kind of come up with this pressure pulse treatment, pressure pulse, I believe that's what you call it. And you use a very old medicine called DAWNS. Sorry, that's the acronym DAWNS you can probably explain that, what it is. My question is about DAWNS, and I'll get into a little bit more of the pressure pulse theory. Is DAWNS, is it main purpose to suppress glutamine? Because glucose and glutamine are the two fuel sources. Is that the main purpose of DAWNS?
Yeah, it's called DON, DON,
Okay, Don. Yes.
DON, and it's
Okay.
6-deoxy norleucine, oxonorleucine.
Okay.
It's a molecule that looks very, very similar to glutamine, the amino acid glutamine. So, glutamine is an essential fuel for driving tumor cells, especially metastatic cancer cells. Metastatic cancer cells that we have found in all major cancers have characteristics of macrophages, which is an immune cell in our body, a very powerful immune cell. They naturally have the capability of moving in and out of tissues. They track down and kill bacteria. They help repair tissues and all this. They are the metastatic cell. They have fused with either a stem cell or have become corrupted themselves. And we know from decades and decades of research that glutamine is the primary fuel for macrophages. So when we discovered that the metastatic cancer cells have all of these macrophage characteristics, the first thing we know from the scientific literature is what they eat. We know that glutamine is a prime fuel for macrophages. If most metastatic cancers are derived in some way or another from macrophages, then we know what they need to fuel themselves to grow, and that's glutamine. So that brought us to recognize DON as a potential drug that could interfere with the way glutamine drives the energy in the metastatic cancer cells, knowing that glutamine is a main fuel for macrophages and that metastatic cancer cells, for the most part, express characteristics of macrophages. So we were pleasantly surprised at how powerful, when we have a model of the best model of metastatic cancer, in a natural model of metastatic cancer, we were surprised at how powerful DON was in killing metastatic cancer cells. Then we looked further and went into the human literature, and many clinical studies had been done in patients with cancer over the years with DON, and it was taken off because they said it was too toxic. This drug it was toxic in the mouse as well. But I met some guy from the pharmaceutical company, a big pharmaceutical company guy, and he said, if you have a drug that's really therapeutically effective but toxic, and you find a way to remove its or reduce its toxicity, then it becomes like a new drug, a new improved. In other words, you maintain the therapeutic efficacy while removing what was previously considered a toxic secondary effect. Well, we found that. We know that when we administer the drug under nutritional ketosis, the level of toxicity from this drug is massively reduced. So if I were to have cancer, any kind of a cancer, brain tumor, colon cancer, whatever, I would be taking DON while in therapeutic ketosis, along with embendazole, which is another drug that can target glucose and glutamine, but not as powerful as DON. DON is the big hammer. When you use DON, embendazole, and ketogenic diets, you get the power of the dietary shift in the body, and you make the tumor cells extremely vulnerable to this diet drug cocktail. And our paper that we published recently in bioRxives shows how in pediatric brain cancer, the number one killer of little kids' cancer death is glioma, a high-grade glioma. And we have a very good model for high-grade pediatric glioma. And for the first time, we use this diet drug cocktail with DON, embendazole, and ketogenic diet. And you can look at the video in the paper. It's unbelievable. And it'll work just as well in adults. It'll work because we're targeting the very essence of what the tumor cell needs to survive. So they can't use ketone bodies and fatty acids. So they're supremely dependent on fermentation. And one of the fermentable fuels is glucose, and the other fermentable fuel is glutamine. and Don is interfering with the glutamine pathway, and the ketogenic diet and albendazole are interfering with the glucose pathway. So you put the two together, and you have a diet drug cocktail that has the potential to successfully manage the majority of metastatic cancers. Problem is, Don is not available. It was taken off, and for all this talk about freedom to choose, or what is it called? There's names for these things that you should be able to. What is it? There's a name for this whole process. A right to try. I think that the term is right to try. The problem is, you go and try to do the right to try Don,